All right, I've got a notification that we're streaming on YouTube, so this should be able to start. I'd like to welcome everybody who's watching tonight. My name's Kyle Ulveling. I'm a cardiologist at Carroll, Iowa for Iowa Heart Center at St. Anthony. I'm also the Chief Medical Officer for St. Anthony Regional Hospital. We've got a great panel tonight to discuss the current status of COVID-19 diagnosis and treatment in our area. Our panel tonight includes Dr. John Evans. He's a family medicine physician at the McFarland Clinic-Carroll. If you guys want to just give yourselves give a wave to the audience as we introduce you. Dr. Greg Perkins is a family medicine physician at the McFarland Clinic-Carroll. Dr. Mark Collison is an internal medicine physician at the St. Anthony Clinic. Dr. Dominick Ervelli is an internal medicine physician at the St. Anthony Clinic. Nicole Schwering is a nurse and the current director of Carroll County Public Health. And Sara Schulte is a Carroll County Public Health nurse as well. I want to thank the panel for being here tonight. I want to thank the audience for taking time with us tonight. The folks on your screen, the 6 panelists, have been doing a huge amount of inpatient and outpatient diagnosis, care, and education in our communities related to COVID-19. But truthfully, in addition to the 6 panelists, there's been an absolute army of nurses, lab techs, physical therapy techs, radiology specialists, OR techs, and then less clinically related things like environmental services and information technology to keep normal healthcare running during this pandemic with all of the added stuff of COVID-19. So even though you're going to be hearing from absolute heavily involved experts tonight, there's an army of people behind all of us that have kept everything going during this pandemic. So just some housekeeping to start off with. We've had an abundance of questions submitted from the public, which I greatly appreciated, made it a lot easier to set up this panel. Because many of the questions were variations on a theme that somebody else also asked, we're going to keep the questioners anonymous. Rather than say that there was 4 people or 5 people that asked this, we'll go through as many of the questions as we can over this next 45 minutes plus, but we're going to keep the questioners anonymous. All right, so we'll just dive in and get started. One of the big topics in the news lately has been a hopeful upcoming COVID-19 vaccine. I'm going to direct this one to Nicole Schwering of Carroll County Public Health to give us an update and what do you know?
Thanks, Dr. Ulveling. So right now, IDPH is talking about they're anticipating a vaccine maybe late 2020 yet, early 2021. Right now, it's kind of still in clinical trials, trying to get it to be the safest and most effective vaccine that we can have. Right now, they're talking about the vaccine. It'll be a 2-dose series. There's 2 different manufacturers. So one will be a 21-day in between the doses and one's a 28-day. And at this point, you'll have to get the same vaccine as you did the first round. So they're saying late 2020, early 21, but that will have a limited amount of vaccine at the beginning. So it'll go to the priority groups such as healthcare workers, residents of nursing homes, high risk people. So they're thinking maybe mid 2021 before it's available to the general public. At this time, there's no cost associated with the vaccine, so it'll be free to everybody to receive that when it's available to everybody. So we're hoping that as soon as that comes out, we'll be able to start administering those vaccines.
And Nicole, when you mentioned you have to stick with the same one, if there's multiple shots of the course, you can't go from vaccine A to vaccine B. By the best of my knowledge right now that there's 3 large-scale trials going on for separate vaccines in the United States. Is that still accurate? Yes.
Yep. There's 3 different ones. So it'll depend on which one you receive the first time, depending on which one you'll need the second round. But right now it looks like all of them will be a 2-dose series.
And then for either you or Sara or anybody else in the panel, could you give us an idea of some of the communications between the Iowa Department of Public Health and the state as far as setting up the procedures to get the vaccine to the general public as soon as we can?
Yep. So the Iowa Department of Public Health will allot all of the vaccines to local public health, and we'll disperse those to everyone that has filled out the surveys to become a vaccine administrator. So as soon as we are able, we've been working here locally with other coalition members just to set up how we're going to distribute the vaccine and who those priority groups will be. And we're giving information weekly on the vaccines. So just trying to get our points of dispensing set up and how we're going to do those groups.
And we expect people's clinics to be one of the avenues of them to be able to get the vaccines, correct?
Yes. Yep. At this point, we'll distribute to the local clinics here in town and in our county to distribute those when they're widely available.
Wonderful. Anybody else on the panel want to give their thoughts or any other follow-up questions regarding a coronavirus vaccine? Seeing none. And this isn't so formal that we can't go back to things if somebody thinks of something as we go on or as more questions come in. Dr. Perkins, one of the questions that came in is about some of the treatments that necessarily don't have the strongest level of evidence behind them. Things like zinc, vitamin C, vitamin D, convalescent plasma, depending on the month. Would you mind giving any thoughts on what you've seen both as an outpatient and an inpatient provider for these treatments?
Well, thanks, Kyle. I apologize for stepping out earlier. I'm actually on call, so I may get called out. There's several things that the majority of us do for patients who are hospitalized. So we give a small dose of zinc, we give a dose of vitamin C, a dose of vitamin D. There's really no hard evidence, though, that this has any survival benefit, but is more based on expert advice from specialists around the country. There's other things such as using Pepsid, using statin type drugs, being on something for antiplatelet and something for anticoagulant as well. Again, without any specific evidence that there's a survival advantage or people leave the hospital earlier based on some of the complications we see. And again, expert advice based on the physiology and the pathophysiology of the virus. As far as doing that as an outpatient, I do think some doctors are recommending patients take some of these medicines, but not everybody is. In the hospital, though, I think the majority of us are.
And then would you also mind giving an idea of risk versus benefit on why, even though some of these treatments you just mentioned don't necessarily have the strongest evidence for use, because of the low risk profile, that helps balance that out? Yeah,
I mean, there's essentially no short-term complications from vitamin C, vitamin D, or zinc. But at the same time, you don't want to just be on zinc forever because it can deplete other cations like copper and et cetera. But they're, these are tried and true medicines that have been around, for aspirin over 100 years. Pepsid's been around 40 or 50 years. Lovenox's been available 30 years. They're all very safe. And so their downside is very minimal, whereas their upside potentially, as you said, is very, if it helps at all, is very good.
And that kind of segues into another question, Dr. Collison, that at the beginning of the pandemic, one treatment in particular, hydroxychloroquine, got a lot of attention internationally, and then got a lot of attention for it being, the evidence being poor, and then eventually the recommendation being not to use it. Would you mind kind of going into more detail with that? And you're on mute.
As you said, initially there was some data that seemed to indicate this medicine was helpful, but for a lot of these trials, the information we're working with is really, really very preliminary. And so as we got more information available, it became clear that this treatment was of no particular benefit. There is another medicine that we were using. It's an antibiotic, azithromycin it's called. And that also was something that we used early on. And the more recent data would seem to indicate that that's not helpful either. And, you know, those of us who do this, that's just the way science works. You know, we work with the best evidence we have, and when things change, then we change with it.
I don't think any of us on the screen, we would all be able to give examples of times where our treatments and our various specialties have changed over the years as new data and new guidelines come out. It's kind of part and parcel of the practice of medicine. Would you guys agree with that? Anybody else want to weigh in on the gentler treatments, hydroxychloroquine, things like that? All right, Dr. Evans, I've got one for you. Would you mind going into some of the data where you've seen in both the outpatient and inpatient practice over the last 2 months where our surge has really happened? Is this from a large gathering where 300 people become infected at it, or is this more small gatherings, household? What information can you give us in your practice?
You gave me that question. Okay. So, you know, there's still a lot of speculation. There's not controlled trials. I think what we're seeing in Iowa is what other relatively unpopulated states are seeing now is our surge came in the last few months. The heavily populated areas on the coast came in the spring, and the Dakotas are just starting to see an uptick. So it's following the population trends like most pandemics do. That being said, what we're seeing in our area, I think clearly is a function of, you know, people gathering and spreading the virus. And some of that is inevitable. I don't think there's any way to completely stop the virus. But certainly, I think it's pretty well established that in general, social distancing, wearing masks, being outside, good hand washing, staying away from people when you're sick, all those things help control the spread of the virus. So a large gathering of people where you're inside and you're not wearing masks is much more likely to spread the virus. That being said, it's very difficult for families to not go to a funeral, to not have a wedding, to not do the things that they have been looking forward to for a lifetime in some cases. And this virus, this pandemic has forced us all to change how we do things. And unfortunately, in order to achieve the goals, which I believe are to protect our vulnerable, protect our elderly and the people with conditions that'll make them more susceptible to the virus, to keep our schools open, to keep our workers working, and to keep our hospitals from getting overwhelmed, we have to have some sort of moderation in our activities or change in our activities in order to allow those things to happen. We're in our surge. The last month has been very busy in Iowa, especially in Carroll County. And I think if we as a community can keep that in mind and restrict the size of gatherings and how we approach those gatherings or delay those gatherings or change those gatherings, it can go a long way to achieve those goals. We can talk more about those specifically if you like, but I think there's definitely a correlation.
One of the things I wanted to do as part of this portion of the discussion, I'm going to try to share my screen, and I wanted to show the up to the moment statistics from the state of Iowa. So this is our positive cases by county. And if you see on this right side, Carroll currently is at an 18.8% positivity rate. So what that means is over the last 14 days, all of the tests that are collected go in the denominator or the bottom part of the equation, and the number of positives goes in the top. So that means nearly 19% of all the tests run in the last 2 weeks have been positive. That metric is used not just by schools from the state or by CDC officials, but by Medicare and nursing homes to decide how often nursing home residents, how often nursing home employees have to be checked. I'm going to go to a different tab here. This graph shows just Carroll County over the last several months of the pandemic. And as you can see, where we thought we had our initial surge over the summer are these smaller peaks in June through August. If you see what Carroll County has been experiencing over September through current, it's markedly more than what we were ever seeing during the summer. Our current number of positives is in the high 300s. I believe Nikki was at 387 today. Was that our number? I'm going to take us off the graph now, so it just should be all of us back on the screen. It's this amount of positives in the community that make it more likely for us to encounter a positive without knowing, without somebody at work or daycare or schools, et cetera. Dr. Evans, is that kind of what you were explaining?
Yes, I mean, the more positives out there, of course, the more chance you have of getting it. The farther away from people, the more we wash our hands, the more we wear masks in public places away from our immediate family, the less chance we have of getting it and spreading it. As you know, one of the most difficult things with this virus is many people don't have any symptoms and they theoretically can still pass it on. And that's the tricky part. When you have influenza, you feel terrible. You have 102, 103 fever and you know you have it, you stay home because you feel terrible. But with COVID-19, you may feel like any other day and be quite contagious. And that's the many tricky parts of this virus.
On that note, the communication, the education that's been nationwide or bigger about the wearing of masks, about how the wearing of masks are not necessarily to prevent the mask wearer from contributing alone. It's as much for that the mask wearer's droplets aren't put out into the public as much, and that two people in reasonably close proximity wearing masks are way more powerful at the prevention of transmission than just one of them are. Is that, I throw that out to any of the panel, including the public health staff members? And by anybody, I'm going to say, Dr. Evans, this is still you.
Okay. Yes, it's an impure science, but the epidemiological studies on that seem to be very, very accurate in that when all parties are wearing masks, there's much less chance of transmission. An interesting corollary is the Southern Hemisphere just finished up with the flu season. And in the places where they wear masks regularly to prevent COVID-19, the number of flu cases are down 80, 90% compared to a normal year. So it clearly prevents droplets. And does it prevent all cases? No, but it greatly decreases the risk of spread. And I would add to that, in the schools here in Iowa, if both students are wearing masks and one of them turns out positive, the other student now does not have to quarantine for 14 days and allows our kids to stay in school, which I think is a great thing for the kids to keep them in school. And because those numbers just exponentially grow when we have more exposure. So that's a great thing for school-age children to know and their parents. So if both kids are wearing masks, we'll have a lot less kids that'll need to quarantine. Our kids are the healthiest. They are the least likely to get it. They're the least likely to have a severe case, but they can spread it, and they do spread it, and especially the older kids. So the less kids that are out, the more kids in school, the better it is for everybody.
I would agree with what Dr. Evans was saying. There is a lack of controlled double-blind studies for masks, but there is an overwhelming amount of data out there if you want to learn about mask science. I've watched several lectures on masks showing significant reduction. So this one scientist was doing a reduction with one mask, and a surgical mask was reduced. And this is aerosolized particles, so very small particles, 5 microns, 83% reduction. And it reduced that if both parties wore masks down to 96% reduction. So it has a significant reduction, even if it's not 100%. Now, the question is, what does that mean? There is some what we would call surrogate evidence that there may be some benefit to having a lower load of virus enter your body. So when the cruise ships that did not have masks had an asymptomatic rate of about 20%. Later cruise ships had access to masks, and their asymptomatic rate was approaching 90%, so a fourfold improvement. And what goes along with that is, although there's a lot of debate about immunization, that it is very possible that these asymptomatic infections are benefiting us as well from a herd immunity standpoint. The reality is, as we all know, there's no great way to monitor and measure our immunity to this, because really most viruses are killed by our T cells. And the way we measure immunity is by our B cells, our antibody. But we don't know how long our immunity will last, but there is some good evidence that even these asymptomatic infections provide significant immunity for a time.
And I'm going to throw this to Sara and Nikki. Sara, you first. One of our school districts locally had to send out information saying, with new evidence from the CDC, we now recommend only certain types of masks for students and such at school. Can you go into a little bit of detail on why there's a reason for a 2-layer, cotton mask versus just a single layer gaiter, why we don't recommend the masks that have the filters in, et cetera?
Sure, thank you. So basically, it's because it actually stops the particles. The more layers that you have, it will stop the particles from spreading. And if both people have it, you have that much better of a chance. If people are wearing like a face shield, there's really only one face shield that's the best. It's actually the Humanity face shield that we've seen. It has the cloth that kind of comes down towards the neck, so it actually helps stop the droplets from getting out from there. The CDC now has come out to say that people can wear gaiters as long as it's a 2-layered gaiter. So again, the more layers you have, the better you have it protecting yourself and that person next to you. Dr. Ulveling, you're on mute.
Thank you. Yep. That was my freebie of the night. Dr. Ervelli, would you mind continuing the discussion as far as the herd immunity? Because that's something that we did get more than one question on. So what does it look like, first of all, if we would have to go with no vaccine? If we would have to go with everybody being naturally immune by getting infected, what does that look like? And you're on mute. Dom, I'm going to say if you go hover towards the bottom of the screen, there should be the microphone that comes up. How about Dr. Collison? Would you mind taking that one?
Well, what it would look like is a lot more serious cases and a lot more deaths. And so that's not really a viable way to do this, especially because we have our younger people who aren't at risk for such serious disease intermingling with our grandparents who are at high risk. So, it's something that's being talked about, but it's not the way you want to control this disease by any means.
So to the best of my knowledge, we've got around 20% or so considered recovered at any given point in time based on our infectivity rates. So what is generally accepted as a threshold before a community is considered herd immune?
I think the number is somewhere upwards of 70%, something like that.
So one of the things that I've seen is that if we have to go from 20 to 70, we have to be willing to also accept about 3 times the amount of deaths in a state or et cetera to try to get everybody naturally immune. And the other issue I've seen is how long the immunity lasts. And Dr. Perkins, you kind of started talking about that. What do we know as far as what do we know on the duration of immunity from infection?
So right now the CDC is allowing people that have been infected to have a 90-day window where if they're exposed again, it's thought that they're not, we would not contract the disease again. So they have immunity. It's very, very likely that's going to extend. the same article that I was quoting about with regard to the cruise ships having this differential immunity, talked about the very few cases of recurrent disease worldwide. Now, this is September of 2020. In the New England Journal of Medicine, they quoted 4. Now, there actually has been more since, and there likely will be more, but that's a reassuring number. If we can get that immunity up through what we have already sustained, and now get that herd immunity up with our vaccine.
Now that brings up a really good point about the vaccine, and I'm going to throw it back to Nikki, since you led off the discussion about the vaccine. So you talked about kind of a hopeful timeline, given what we know and logistics of how we do it. One thing we didn't mention is the vaccine actually has to get into people, right? So we can't just have a vaccine available, people actually have to get it. So
Yeah.
what do we see as far as people who get flu shots should get coronavirus vaccines? Or can you go into more depth as far as how that message gets out?
Yeah, so of course, we're going to be encouraging everyone to get it. Just like everyone has said, it's going to build that herd immunity for everybody. It's going to help protect us. We're still going to have to be wearing our masks and doing our social distancing after we get the vaccine for a while, but it takes time to build up that immunity, and hopefully we can get a great population of people getting it and doing the social distance so we can bring down our numbers and hope, get back to the new normal of what we're going to be seeing for a while. And then that brings up a great thing too, I wanted to mention about flu vaccines. It's more important this year than ever to get our flu vaccines. The symptoms can be the same between the flu and COVID. So we just want to make sure that everyone's getting the flu vaccine this year, just to protect them from getting sick and, again, from overwhelming our hospitals for the influenza when we're really needing those beds for COVID this year.
Thanks. And one more point about the immunizations on both. Like influenza, just because when we do get a coronavirus vaccine, somebody's not immune the hour after they're shot, correct?
Correct. Yep. It's going to take a while to build that immunity. And that's why it's going to be a 2-dose series, because it's going to need to get that booster, just like other immunizations too. And just like the influenza vaccine, it's not going to be perfect, but it's going to be better than what we have now.
Thank you. Dr. Ervelli, thanks for your patience. I'm going to have you take us in a different direction. So one of the questions was, what would a worst case scenario look like in Carroll? In other words, where our numbers don't go down, our transmissibility remains high, people continue to get sick and hospitalized. So take us in that direction. What would that look like?
Well, right now we have the concern would be overwhelming of our system. We have the 12 beds that we have presently right now for the COVID unit. We have the ICU, which has 6 beds available in the emergency room. But we'd like to keep the people presently right now in the COVID unit, which has been full at times. Our other concern there is using up what we have. We usually put people initially on oxygen, then they go to high flow oxygen. Then the next step is vapotherm, which is even higher flow. And then from there, if they are deteriorating or not responding, it's going to the mechanical ventilation. We have to have the talk with the patient and the family. Sometimes it's urgent and it's it's a very sad talk. We have to tell them, have your talk with your family, tell them you love them, and you'll see them soon, hopefully, God willing. And then we intubate and transfer through a very complicated process, trying to keep all the safety measures in place. But if we have no place to transfer people when they're on the ventilator, that would be our major issue. Then having to keep them here, we would have to manage them and use the resources that we have. Our present vapotherm numbers, I think, are 6 to 8. And then when things run out, then mechanical ventilation, We have our 4 ventilators and I think 4 other machines that can be used. But if we run out there, then we get into that situation in April and March where everybody was worried about telling people there's no ventilation available. We have no place to transfer. That would be the worst case scenario I could figure. Plus also nursing staffing, staffing of other ancillary staff, radiology, the ER staff. Last but is the doctors, but there's plenty of other people, like you said, are involved in the care of the patient. And overwhelmed, we even talked, if you can remember in April, when we talked, when everyone was shocked at a possible 150,000 dead. Now the number is up to 270. We were talking about using and if you can remind me of the plastic tubing to try to share ventilators.
We were talking about, and we've still got this as part of a backup policy of using T-tubes to connect more than one person to a single ventilator.
Yeah.
And hospitals in the United States had to do that.
Yes. Hopefully that never comes to our area, but it could happen.
On this, the worst case scenario, you mentioned the staffing. I'm going to ask for just a show of physical hands, not raising hands on Zoom, but if we're overtaxed, where we don't have either PPE or bed availability in a hospital or staff availability, between those 3, my personal feeling is that I think I'm more worried about not having the staff right now based on our community spread and what we're seeing with healthcare facilities, with long-term care facilities, with group settings. This isn't just about the elderly or the infirm. These are also facilities like New Hope Village and other resources in our area. My feeling is that I'm worried about staff more than PPE at this point. What are your 6 of you fellas and ladies, what do you think?
Well, I think that we are already having problems with nursing staff. We've had to have, some of the nursing staff has been helping with control of people coming in and out of the hospital and, working extra shifts in the COVID unit. So I think we're already having problems with staff. So I agree. I think that's the biggest problem.
Anybody have any contrary thoughts? So one thing, while we're to try to take us out of the worst case scenario stuff and go back to the measures that can help us. Honestly, we had several questions that were submitted about mandating masks on some level, whether it be state or whatever. And I'll just say that, one of the things we talked about is that we're here to help educate everybody, to be resources to everybody, but we're not elected officials and we're not the proper forum to necessarily be to make that decision. Is anybody else want to go any further, or I'll open it to the crew?
It is it's a charged question. Dr. Evans touched on a couple of things. I brought up some things. We're looking at really surrogate evidence that masks are functioning. And those of us here, plus the other providers and the nurses in the community, are a good testament to how well masks have worked and protected us. Many of us do have extra protection beyond just the surgical masks, using the N95s in the hospital, but the majority of us in our clinics who are exposed are just using regular masks. And to my knowledge, we haven't had a provider get this. We've had some nurses possibly get COVID, but it was questioned where they got it. And I don't believe any of the COVID nurses have gotten it. So masks seem to be good in that regard.
Well, and I'll even go a step further with that we have very clear evidence, both locally and nationally, that the right PPE used properly, in other words, putting it on, taking it off, disinfecting yourself with all those steps, but PPE properly used works very well. Is that fair for everybody?
And one of the other surrogate evidence that I think is reasonable to use is when you look at other counties. So I'll use Johnson County because I have a daughter there. When they started school back, they had about 2,000 cases almost right away, about 120 rolling average per day, really incredible. But when you go there, it's a mask everywhere. It's a mask in town. So the mayor has mandated masks and the school has. And right now, if you look at their numbers in Iowa City, their numbers are 5 to 10. It's unbelievable per day. But those are really great numbers, and they've been down. Whereas the rest of the state looks like it's up, Iowa City's been down. And I realize these aren't controlled studies, but that's what you're going to have to look at with masks, is looking at surrogate evidence, looking at other things that may mark for benefit.
Thank you. I'm going to throw a curveball, and I'm going to send this. These are questions that have come in during the meeting. And Dr. Perkins, I'm going to leave it with you. Dental appointments. So the 6 of us on the screen deal with bread and butter healthcare things all the time, and are trying to do those things in addition to COVID. What do we know as far as taking care of these other preventative health things that aren't necessarily part of our day-to-day, like our regular dental appointments? What advice have we seen, and should we be giving to the public?
Yeah, I think we need to get back and do dental appointments. I visited with my dentist. In fact, I missed my appointment during the middle of the COVID shutdown, and he's sent several invites for me to come back. He and I visited, actually. The American Dental Association does have some guidelines and recommendations, and the providers in our town are instituting those. They're wearing their N95s. They have face shields. And so I think that as of right now, there's no reason for us not to be getting back and seeing our eye doctor, seeing our dentist, doing other preventive health maintenance that is important, being at the audiologist, et cetera.
Anybody else want to weigh in? Well, one thing else. Oh, go ahead, Dr. Evans.
I think the dentist and all the other health professionals are following the guidelines. The dentist in particular have been used to this type of protection for years, wearing masks and bodily fluids and so forth. So this was a natural progression for them, the addition of the N95 masks and the double masking. But I think the numbers would bear out that people aren't getting infections in those situations any higher than any other place, which is extremely low. And I would encourage people to not put off those visits and to get their healthcare needs met. The whole key to this is keeping society open in a safe way.
That actually brings up a really good just segue as far as that. Does anybody on this panel want things to shut down the way they did early in 2020? The goal is to keep doing things like school and restaurants and things like that, but do them in a safe way that keeps them open and keeps the staff and the patrons and the students and the teachers all healthy, right? All right. Another kind of a not easy transition subject, but one of the questions, actually more than one question brought up the comments that COVID-19 is being overdiagnosed in order to make extra money. Dr. Evans, I think I'm going to throw that one at you. Can you please just say, give us your response, and also some of this is tied to how death certificates are filled out, and maybe just give a brief explanation on why something might be a contributing diagnosis and why COVID-19 may be listed.
So I don't see anything in my practice where diagnosing COVID-19 would be beneficial financially. It has disrupted every form of the economy, including healthcare. And all of us would love to never see another COVID-19 patient or death or illness. In terms of the government, the question probably refers to government payments in regards to COVID-19 care. And as we all know, the stimulus package helped a lot of society through unemployment, as well as hospitals and clinics to take care of patients with COVID-19. But in terms of making the diagnosis to make money, I think that's grotesque. In terms of death certificates, I'm not sure of all the innuendos or the details there, and I would defer a little bit to Sara and Nikki at Public Health, but the state always wants to know what the death is and was COVID involved, as much for statistics and epidemiology as anything else. So if a person died from COVID-related pneumonia but had underlying conditions, you place all of that on the death certificate. So I don't think there's a monetary carrot at the end of the stick that you get for making extra COVID diagnoses.
Thank you. Nikki or Sara, do you have any further detail to throw in? All right. An analogy, Dr. Evans, for like, if somebody was a lifelong smoker and had COPD that was requiring oxygen for several years towards the end of their life, and if they died from pneumonia, would it be reasonable to say that their death certificate may say pneumonia complicated by COPD complicated by tobacco? Would that be?
Right. So you first list the cause of death, and then you list all the underlying conditions that led to that. And then you're required to say the time frame that those occurred. How long was the pneumonia? How long was the COPD? How long was the heart failure? So that the whole picture can be taken into account, not just a single diagnosis.
On that note, the one thing that I think may not be clear to people who haven't been dealing with COVID-19 for 7 months, like our 6 panelists, Dr. Collison, would you mind, pneumonia and respiratory failure are not the only complications from COVID-19 infection, correct?
Correct. Fortunately, that has been, the respiratory complications have been the biggest thing that I have seen. But yes, there can be strokes, there can be heart attacks, there can be gastrointestinal things, there can be kidney failure. There are lots of other scenarios that are potentially very serious also.
So somebody doesn't have to be only with pneumonia to be suffering effects of COVID-19.
For sure, for sure. One thing I think I'm going to add is that when we talk about the number of people with this disease, I think we have to understand that we are not diagnosing everyone. So we can say without a doubt that the numbers are actually higher than the numbers that we report. That's the way it is with any disease, that we see the sicker people, the people that we test. And as you were saying, those people who are asymptomatic, aren't having any symptoms at all, well, we're not going to pick up those people. But when people say, well, it's really inflated, no, our numbers are lower than they really are.
The only other way of doing it would be to do like the repeat bubble testing, like some of the sports teams have done, where they just say, we're going to keep testing this exact same population maybe 5 times a week, right?
There's been studies that say that there's up to somewhere between, there's low numbers and there's high numbers, but the high numbers are up to 10 times greater than what your numbers really are. I don't believe that that's probably where we are in Carroll, but I completely agree. It's more than 1x. It's somewhere between 2 and 5x, I would think.
So I've been given a 2-minute warning by our producers. So I'm going to do, so for one, we've had over 400 people watching in the public for the YouTube live stream. And I want to thank all the members of the public that have tuned in tonight, just to hear from, like I said at the beginning, there's an army of people behind the 6 panelists, but these 6 people have been doing a huge amount of inpatient, outpatient, school, education, COVID-19 treatment. So I'm going to rapid fire some questions. I'm just going to kind of go around the ring, and you guys can bounce it to somebody else if you want to. Dr. Ervelli, is there any correlation to blood type and either severity of illness or susceptibility of illness? What do you know?
From the last time, there's so much information out there, but the last set I read is that the O negatives have possibly the least chance of testing positive. There was talks of A positive. I don't want everybody to panic out there, but A positives being a possibility of they're more at risk. I don't think they're. I'd have to defer to somebody else if anybody else has read anything new about that.
I've
But
seen
O
similar
negatives are less apt to test positive.
That doesn't mean O negatives are superheroes. And that doesn't mean A positives are definitely going to get it, but it's a matter of risk.
Right.
Dr. Collison, any other health matters besides dentistry? Like, are you aware of any reasons why people shouldn't go see their eye doctor? Why people shouldn't be doing the other preventative measures unless they're told to specifically by their physician or provider?
No, I can't think of anything that would change what you should be doing anyway.
Dr. Evans, at what duration after infection are we seeing some people affected? In other words, is there a peak where we worry about people getting worse?
So it seems as between about days 5 and 10 after the onset of symptoms is where the severe respiratory complications come in. Some people, of course, have little or no symptoms all the way along, and that's wonderful. Other people start off with fever, cough, aches, but are doing pretty well. But long about day 5 is where the inflammatory response takes over in the lungs, and that's where the people are very, very sick. And so we try to stay in close contact with these patients, calling them on the phone, doing monitoring at home to help them decide whether they need to come in for more treatment or be hospitalized to keep them from getting extremely ill.
Thank you. Sara, can you give us a brief explanation on what it's like to do contact tracing? As far as, we'll say that Kyle got a positive COVID test. I got tested because I started having fevers. When you call me, what does that contact tracing look like?
Sure. So basically what we're going to do is we're going to ask you, who do you think you maybe came in contact with? Where were you at? What kind of conditions you might have, such as asthma, heart, liver, kidney issues. We're also going to ask you who you were in contact with. And our contact tracing is only as good as what the individual gives us. So if they don't give us any names, we can't call anybody. So that's a quick synopsis of what we do with contact tracing.
And then Nikki, on that same note, do we ask, so again, let's say that Sara called me and did that evaluation with me over the telephone. Do I have to do certain things? Do I need to contact people that I, were at work with or things like that? What, maybe explain like the quarantine, like what are my responsibilities after I've been contact traced?
So we would just ask you when your symptoms started. So your quarantine would start 10 days. It would go 10 days from when your symptoms started. So day of symptom is day 0. You go 10 from there, you release the next day. And then as far as you contacting everyone, we'll ask who you were in contact with those 48 hours prior to symptoms up until you got your results. And then we'll ask for the contact information and we'll contact those people to let them know that they need to be quarantined then 14 days from their last contact with you. So if you got sick on Monday and was with someone on Saturday, their 14 days would start then on Saturday. And we would encourage them to isolate those 14 days.
Sorry, Nikki. And then the 10 days for a positive, that's kind of a best case scenario for somebody who had minimal to no symptoms recovered quickly, correct?
Correct. Yep. And then
they go past 10 days if there continues to be sick or if they have to be put in the hospital, things like that.
Correct. Yep. They have to meet the 10 days and they can have a fever within 24 hours of that last day. And their symptoms have to be improving. So if they're still not feeling well, their quarantine goes until 24 hours after their symptoms have improved. And people that are immunocompromised, we suggest that they isolate for the 20 days then, just to give them a longer period of time to recover.
Absolutely. All right. Does anybody have anything for the public? There were still questions coming in just as Dr. Evans, Sara, and Nikki were talking. So we thank you for everybody, and we're sorry if we didn't get to everybody's questions. We tried to get to as broad of a swath as we could. To the 6 panelists, anything that you guys would like to make sure we cover?
One thing that I'd like to say, as Nikki said, the influenza vaccine is extremely important. We are all concerned about what happens with people who have influenza and COVID, and how those two interact. So the influenza vaccine is very, very important. And hopefully our numbers will be less because of the masks. We all hope that occurs.
And that goes, it's absolutely worth repeating for a third time, that these aren't COVID prevention measures, these are infectious disease prevention measures. So they won't just help for coronavirus, they will also help with things like influenza. Thank you, Dr. Collison. Anybody else want to do any other topics? Dr. Evans?
I would just add one thing. This week looks beautiful weather-wise, but next week doesn't. And as winter comes on, more and more activities will be inside. And I think that will change the dynamic of our COVID numbers. So I think it's a perfect time to talk about just taking care of each other in the community so we can protect our vulnerable, so we can keep the schools open, keep people working, and keep our hospitals from being overwhelmed. So the CDC guidelines are just that. They're guidelines. They're not perfect, and they may change. But if we all follow them and take care of each other, we'll look a lot better on the other side of this, whenever that is.
Thank you, Dr. Evans. I'd actually use that as a good closing motive to all of us, that the public watching this, you guys are our biggest partner right now, that all of the healthcare workers will absolutely continue doing our best, but we can only do so if we're able to. And every single time a daycare or a factory or another place gets multiple cases, that dramatically increases the chance of one of our nurses, physicians, surgical techs being taken out of the healthcare pool because they're either exposed or now they're positive also. We can't provide help to our most vulnerable in the nursing homes, to the long-term care facilities, if our healthcare workers get exposed in the community. So you guys are our biggest partner. You guys have the most power to help bring our numbers down. And that's the reason for Dr. Perkins on a call night and everybody else for doing this. So to our 6 panelists, thank you very, very much for taking your time. To the public watching, thank you, and please treat each other well and do our best to protect each other. I'm going to put one special note. It doesn't escape anybody that tomorrow is election day. The vast majority of election workers in our communities are typically of retirement age, and this has been a very difficult year for them to continue doing their work. There's very few more patriotic things than putting yourself at risk for your country, things like that. I just say that for those of you voting tomorrow, take just an extra 2 seconds to thank the poll workers that are doing it, because like I said, it's not a normal year for them either. So anything else from the group? Otherwise, thanks everybody and have a wonderful evening. For the future, if there's a lot of positive feedback, we'll try to get either this panel or plus or minus some for more questions if that would help the community. So thanks everybody and have a